barriers and disincentives we surfaced through this analysis are organized into 7 main themes, which I'll touch upon at a very high level in the slides that follow. I'll also include a few quotes from the interviews that are shown throughout the presentation in quote bubbles, like on the right. And as you're hearing about these barriers and disincentives, you may feel like this person who said, everything is designed for integration not to happen in terms of the way the system is organized, the way it's financed, the way it's resourced, and the way services are delivered. But not to worry, it's not all doom and gloom. At the end, I'll preview 3 bodies of work that the HCE Coalition will be engaged in to address these barriers and disincentives and improve collaboration and integration. The first theme relates to the overarching global aid and financing architecture. And this is not unique to campaigns and relates broadly to vertical programs. There are fundamental issues in the way global health is structured and financed, which enforce verticalization and fragment the system. Funders have different stovepipes of funding, restrictions due to receiving directed money, and team structures that are built around these stovepipes. Funders want to know their ROI, their return on investment, and are interested in attribution, or at a minimum, contribution. And demonstrating results against expenditures for directed money can be more challenging in integrated programs. The quote on the right illustrates this point. There are clear incentives for donor-led programs because you have very clear outcomes. By joining with other donors or other vertical programs, or by investing in more horizontal structures, you cannot as easily tease out that direct impact. And some programs are well-resourced and others less so, with significant differences in scale, making the imperative for integration different. So for example, the budget for tetanus is 100th the size of polio's. Another example is vitamin A supplementation, which is referred to as an orphan program. Or within the NTD community, a concern about dilution in an integrated scenario as other health priorities often come first. Continuing with this theme, fragmentation is enforced at every level, with each subsequent level accountable for reporting to funders against individual mandates. And the existing funding structures and entities have resulted in many implementing partners that are not set up for integration. You have disease-specific departments at WHO and UNICEF, for example, and you have a number of organizations with disease-specific missions, such as all the site NGOs whose funding is dependent on eye care. And the disease-specific funding arrangements have created a fragmented financial system, which has been replicated at the country level in these vertical programs. Let's look at these quotes on the right. Every donor has its agenda. Every grantee will follow the money. Funding channels are siloed, but often in government, you see a mirroring of those silos in the government structures themselves. The second theme is around unproductive competition and power dynamics. Now, organizations and diseases compete with one another for scarce resources and priority. And fears of integration typically include relating to having a more modest control of resources. Donors also compete for philanthropic and other donor funds. They compete for expertise and influence, and they compete to demonstrate and claim results. So what this leads to is a redistribution of resources at the global level. Organizations have to vie for political influence, and they often center themselves in solutions and how they define success, which leaves little room for collaboration. Here are some illustrative quotes. This game playing, these turf battles occur when you know there's something in it, either power or money or both that are associated with campaigns. There are bureaucratic fiefdom issues. You have these interests of people's jobs, people's careers, people's teams and structures that are all organized around a funding stream. The third theme is around fragmented financing. There's a lot to go through here. I'll just touch on some high points, but there are distinct financial flows, funding sources, timelines, and reporting across health programs, partners, and campaigns. And the independent funding cycles of campaign donors and implementing partners don't synchronize with country processes or fiscal calendars. There's differential remuneration of health workers and community volunteers that are supporting campaigns for different programs, and this can really introduce distortions. And there are inefficiencies from overlaps, duplications, and misalignment of campaign functions or components. So for example, multiple population enumeration efforts targeting the same communities by different programs in the same year. The next theme is called the tragedy of the commons, where there really is no incentive to change the status quo. Any benefits of campaign integration would accrue broadly. So this means they would be shared across the system, and it's not obvious to a minister of health or finance to whom any cost savings would accrue. And who bears the cost of not integrating? There are no immediate negative consequences. For donors or siloed funding channels, the financial cost or financial inefficiency is borne by the multiple channels. Each distinct channel does not see the inefficiency. And for country governments and vertical programs, they're not feeling the inefficiency either if campaigns are primarily donor funded and there are no opportunity costs to the government for that donor funding. The quote is quite powerful. As long as the campaign space sits within external funding mechanisms, there is no incentive for integrating within the system. Efficiency isn't part of that domain. The next theme is around powerful disincentives, that actually multiple standalone staggered campaigns have some obvious benefit. Now, people and programs may be reluctant to support campaign integration because there is a perception that it would have a number of negative consequences. For example, would integration erode focus on a particular disease with the dilution of mandate, leading to lower campaign efficacy, lower coverage, lower impact? Would it jeopardize the special protected status of eradication if you take your eye off the prize? Would it reallocate funds away from the least prioritized diseases? This is another example with NTDs. Would it increase the cost of better resourced interventions that others piggyback on? For example, polio, measles, or seasonal malaria chemoprophylaxis. And finally, a major one, would integrated campaigns lead to lower per diem or stipend payments for health workers and volunteers? This being a critical source of their income in settings with low or delayed salary payments. So this quote on the right really illustrates this point. Why would I do integration if I get a lot less money and my staff are less happy because they're not getting those little incentives? This theme is on lack of coordination, intra and intercoordination. Global partners do not coordinate their strategies, align funding streams, or create plans that enable coordination downstream. There's disjointed planning with cycles happening at different times across programs and partners. And discussions about campaigns are happening with different parts of government, sometimes overlapping, sometimes not. And there's really limited policy dialogue or awareness outside individual verticals in many countries. Let's look at this quote. Across various government teams, there's often not a venue for integrated planning discussions to happen. Everyone is focused on their specialized area. I don't think there is a platform to discuss cross-learning. The final theme is integration is complex and change is hard. First, country absorptive capacity is limited in this moment. There are so many competing priorities, particularly now with the pandemic. And donor and partner coordination is difficult. There are high transaction costs to do this. There is already concern for overloading an already overburdened health workforce. Additionally, ensuring quality standalone campaigns can be complex enough without adding on additional populations and interventions, making it a bit of a risk to layer on for reasons of efficacy and quality. There are also challenges aligning funding and commodities and campaign activities across different interventions and antigens. That timetable can be really tough, particularly with delayed disbursements and so on. And many funders have institutionalized grant-making processes and systems, which also may require a big change. So an interviewee shared this complexity with me by saying, the complexity of piecing together money, personnel, commodities from a variety of programs takes a lot of time. Coordination and leadership and putting all of those pieces in place is challenging.